Bonjour à tous, bienvenue. Il y a encore personne, donc attends un petit peu. Ça c'est classique, hein, ça c'est... on attend. Midi 30, oui. Il y a toujours des retardataires. Voilà. Bonjour à tous, bienvenue sur le Lunchtime Conference de Notre Bon Droit Europe. Merci d'être là. Bonjour Isabelle. Bonjour Elisabeth.
Bonjour.
Aujourd'hui, nous recevons le docteur, professeur Elisabeth Paul. Merci d'être là avec nous. Je vous rappelle que la session est en anglais, mais effectivement, vous pouvez poser vos questions aussi bien en français qu'en anglais dans le chat. Également, on sait que ce n'est pas évident comme horaire, donc vous allez nous rejoindre au fur et à mesure, mais évidemment, la session sera en replay et vous aurez évidemment le lien. Donc, je vais passer à l'anglais. Et n'hésitez pas si vous avez des questions. Pour ceux qui ne veulent pas, j'ai oublié de dire, pour ceux qui ne veulent pas se loguer sur le site de YouTube, vous avez la possibilité de nous envoyer en live pendant la conférence vos questions par email sur notre bon droit. Donc, notre adresse email, c'est notre b-droit@protonmail.com. Isabelle, si tu peux le mettre dans le chat. Et comme ça, on prendra vos questions au fur et à mesure pendant le live. Voilà. So, good afternoon, everybody. I'm Stella from Notre Bon Droit Europe. Good afternoon, Isabelle. Today, we actually have the pleasure to host Dr. Elisabeth Paul. Hello, Dr. Paul.
Hello.
Elisabeth Paul is an associate professor and consultant in Université Libre de Bruxelles and University of Liège. She's specialized in global health policies and system and development aid. She holds a PhD in management from the University of Liège, and her thesis was on improving public outcomes in developing countries, application of incentive theory to aid and public resource management. She had led over the years a double career in the fields of global health and development cooperation as a development expert to various missions at international level, and as an academic, because if I'm correct, you are currently an associated professor at the School of Public Health of Université Libre de Bruxelles. So thank you for joining us today. As I was saying in the beginning, the session will take place mainly in English, but for all colleagues interested, they can ask their question either on the YouTube chat in French and in English, or during the conference. If you don't want to log in, you can directly send your question to our mailbox. Isabelle put it in the chat, contact@notrebondroit.be. And we will take them one by one. Today, we have the pleasure to host Elisabeth, who is going to make a critical assessment of the COVID-19 response in Europe and paths for a real public health policy, which I think is, considering the context and as we see over the last days and weeks, things happen in a very, very fast way. Let's say there are changes, or let's say turnaround, let's say, in public health policy in many member states, including in Belgium. So it's very important we have our insights in order to understand what is at stake and what perspectives basically we can expect. So Elisabeth, you have the floor, and thank you for joining us today. Thank you.
Thank you very much. Good afternoon, everyone. So I'm Elizabeth Paul, and as a few words of background, I would like to say that you probably have seen that the COVID-19 pandemic caused an unprecedented response worldwide, but the response was adopted in emergency and in a command and control way. The pandemic showed a critical lack of preparedness and also governance deficiencies, both at the global level and at the national level, with a lot of fragmented decision-making processes. And also the fact that local health systems and primary healthcare have been forgotten from the response. The response is mostly based on what we call the Pasteurian paradigm, which says that for each disease there is one vector, one germ, which is at the origin of the disease. And so the sole issue which has been targeted by the response is the virus, the coronavirus. And other health conditions and other health determinants have been forgotten from the response. We also see that there have been a lot of one-size-fits-all measures which have been implemented across and within countries, with the measures untargeted on specific populations, but dealing with the whole populations. We have seen a rapidly evolving evidence-based, which has not been followed by the adaptation of policies. And I would like to also point to the fact that the infection and the mortality profiles of the disease have been very much heterogeneous across the globe. Initially, when the pandemic hit the world, we were announced a very high case fatality rate of about 3%. But actually, a few months later, it was disclosed that the average infection fatality rate, which is the actual lethality of the virus, so the number of people who have been infected and who actually die from the virus, is actually very low, about 0.2%. Yet with important variations between ages. So I read no later than yesterday a paper by some French scientists who show that the lethality rate of COVID-19 is increased by a factor of 100 between 25 and 65 years of age, and it is multiplied by 1,000 between 25 and 45 years of age. So it is a very heterogeneous disease. And I would like to recall that the mean age at death in Europe during the first wave was between 80 and 82 years of age. So I will now turn to presenting the variation of the pandemic in Europe. Here is a map showing the cumulative confirmed cases per million people in Europe. And we see that overall, European countries have been hit in a more or less similar manner, except for Finland, which been outsider, but basically around 100,000 and as much to 500,000 cases per million people in many countries in Europe. Yet the profile of the death per million people is very much different. So if the number of cases per million is more or less the same in European countries, it's not the case of the death. And we see that some countries have been, especially in Central and Eastern Europe, have been hit much more than other countries, and especially much more than the Northern Europe countries. Here is a map of the case fatality rate of COVID-19, so similar to the previous map. We see that some countries have managed to limit the number of the case fatality rate of the disease, but it's not the case in Central and Eastern Europe in many countries. And here is an evolution of the case fatality rate of COVID-19 with time. And we see that the case fatality rate, so that is the number of people who are officially confirmed with COVID-19 and who actually die. And we see that during the first wave, and actually most of the first year of the pandemic, the case fatality rate was very high in many European countries. But now the case fatality rate is much lower than was the case in 2020. What can explain that? Actually, there are a number of factors which can explain that. We perform more tests, so that means that the number of cases is better known than during the first wave. We have better treatments. We have better immunity among the population, both from natural immunity and from vaccines. And perhaps the current variants may be less lethal than the first Wuhan virus. So here is a map of the stringency index of the policies currently in Europe. So it's a composite measure of the different response measures which are implemented in Europe, and we see extremely wide variations across countries, with some countries being very cool, and while others are very stringent with the population in order to control the pandemic. We see that the stringency index has evolved a lot across time. And we see that at the beginning of the pandemic in March 2020, many countries were reacted in a very stringent way. But actually, we also see that they maintained very stringent measures all along the pandemic, even in summer times, for instance, when the countries were not in a real epidemic peak. Here is another index. It's a containment and health index, so including public health measures. And we see once again that some countries implement very important and a large number of measures to control the pandemic, while others are more laissez-faire, adopt a more laissez-faire approach. So now we turn to the number of tests which are positive currently in the past week in Europe, and we see that once again we see a wide variation of the share of tests which are positive. But of course, this doesn't mean this can mean that the countries in red have a very strong epidemic at the moment. But this indicator is also very dependent on the number of tests which have been performed. For instance, this graph shows that the positive rate of tests with the number of tests per million daily in Europe. And we see, for instance, that of course Denmark has a lot of new confirmed cases per million, but it performs a lot of tests in its population, while other countries like Sweden and Germany perform less tests. So it's important to understand that this kind of indicator is very much dependent on the policy which is conducted in a country. Now we turn to vaccination, and we see here the share of the population which is fully vaccinated against COVID-19, and we see that Spain and Portugal and most of Southern Europe and also Northern Europe have a very high percentage of the population which is fully vaccinated, while vaccination is far less generalized in Eastern Europe. Here is basically the indicator which is most relevant for public health perspective. It is the death from all causes compared to the projections. And we see the wide variations in Europe. We see that countries which are supposed to be very hit by the pandemic, like France, for instance, actually have a quite low excess death compared to what is expected. And we see that other countries, especially in Eastern Europe, have a very high excess death, all causes, probably linked to the pandemic, but also perhaps to the side effects of the measures implemented. And so we see a very important variations within Europe. And if you see, for instance, the 3 Nordic countries, they are very much similar in terms of excess death, while they have very different policies. And we see that Spain, for instance, which is known to have been very hit by the first, especially by the first wave of the epidemic, actually has quite low excess death. So what can we say about the response measures effectiveness in Europe and elsewhere in the world? Actually, we can say a lot about the effectiveness of the measures implemented, because the country comparisons make little sense. Indeed, the context, the structural factors, for instance, the climate, the season, population density, and especially the age pyramid, so the age structure of the population, it matters a lot. So you can just compare 2 countries without taking the context into account. I have also tried to show that the indicators we use are policy dependent. For instance, the case fatality rate depends on what is accounted as a case, and this is dependent on the testing policy. Same for the occupation of intensive care units. Not all countries have the same policy in terms of treatment, in terms of hospital management, etc. So you can just compare 2 countries based on single indicators. So it's important to conduct a proper evaluation if you want to really understand what is the effectiveness of measures. But there are methodological challenges to do so. First, a very important challenge is to reconstruct a counterfactual. A counterfactual means that you have to reconstruct what would be the situation if the measures had not been implemented. And this is very difficult to do, because you probably have seen and understood that the predictive models about the epidemic have all proved to be wrong. And so it's extremely difficult to try and construct a scenario of what would have taken place if other measures had been implemented and not what we observe in reality. Another challenge deals with that it's even difficult to assess the direct effects of the measures on the epidemic. For instance, it's more or less easy to assess the effect of for instance, lockdowns on the circulation of the virus. But any measure not only has direct effect, but it also has indirect effects and costs. So those indirect effects are very difficult to assess and to measure. For instance, we know that lockdowns will create poverty, and poverty will create bad health. And how far do you go to measure the indirect effects of the measures? Another challenge deals in the difficulty of disentangling the various measures' effects. Indeed, in most countries, we have an accumulation of different measures which change all the time. And it's very difficult to attribute a result to one specific measure, considering that there are plenty of other measures at the same time. And finally, you have to know that a challenge in evaluation in general is what we call a policy implementation gap. No policy is implemented exactly as it is written on paper. And so it's important to understand what people and how people really behave. And you have to understand that it's not because the countries are locked down on, for instance, on a Wednesday, that the circulation of the virus was maximum until Tuesday night, and everything stopped on Wednesday morning. So this makes it very difficult to evaluate what are the effects, the whole effects of the response measures.
Elizabeth, can I ask you a question? Sorry,
yes.
Perhaps in order to make it more interactive. It's really interesting. I see on your slide, you say predictive models are wrong. How can you understand that those modelization in some member states took so much importance that all public policy in those specific member states have been based basically on models which are completely irrelevant? Or actually, at the end of the day, we can see that those models, for instance, for last year, perhaps you can tell us if you know more in some countries, were completely wrong, and we based all the policy on those. How is it even possible? I know they needed to anticipate, but why did they get it so wrong? I don't know if you can answer that. I will say it in French for those colleagues who want to ask question in French. Je demandais à Elisabeth, en fait, puisque je vois sur son slide qu'elle parle des modèles, des modélisations prédictives qui sont fausses. Comment est-il possible, de son point de vue, si elle peut nous répondre, qu'on se soit basé sur des modèles qui sont aussi faux, mais qui ont en fait été la clé de voûte de la santé publique de tant d'États membres? Et comment on peut, je comprends que les gouvernements devaient anticiper, mais comment on peut concevoir qu'ils se sont basés sur des modèles qui sont si faux? Voilà. Et comment c'est possible qu'ils soient si faux? Voilà. Qu'est-ce qu'ils ont loupé? Ou voilà. Si Elisabeth pouvait répondre, ça serait très utile. Merci.
Of course, my understanding is that the governments are wired in a new public management way, and they have the illusion of control, and they manage the crisis through indicators, and they have the illusion that you can control a virus and that the problem is complicated. So when you have a complicated problem, you can manage it through models and through linear causal relationship. Yet those people don't know that the health systems and health in general is not a complicated phenomenon. It is a complex system. And complex systems cannot be controlled from the outside, and they cannot be, the evolution of a complex problem cannot be predicted through a model with linear relationship within it. Because the causal relationship are not linear. It is what we call a generative causal relationships. So the governments have been advised by people who have taken the wrong model. They believe you can control a complicated phenomenon, but it is a complex system, and the complexity in health science is a new field of investigation, if you want, but still few people can deal with it. And the government structure of all our government believing that you can control human behaviors and the like are totally wrong. It's a real illusion of control and a mismanagement of not taking complexity into account. I hope I responded to your question.
Yes, thank you very much.
I will
yes.
speak a bit further, a bit later about this complexity. Returning to evaluation, we have been focused on effectiveness of measures. When you hear the discourses from the media and the government, what is the effectiveness of measures in terms of limitation of cases, of deaths, etc. But effectiveness is actually not the only criteria to evaluate. You also have to evaluate the efficiency. So what are the results compared to the costs, compared to the resources which have been invested? For instance, in health economics, you will never accept a health intervention if the cost-effectiveness ratio, if the efficiency ratio is not good. So if it costs too much per year of life saved, and this kind of studies have not been done in the current crisis. You also have to think of sustainability of measures and also of equity, which is the distribution of the benefits, but also the costs of the measures. For instance, there are plenty of studies showing that the response measures have a weight in a discriminately, in a non-proportional way on the poor. And the measures have exacerbated the existing inequities in our societies. Moreover, you also have to compare one measure to the possible alternatives. And I have the feeling that in many countries, no alternatives were compared. There was one size fits all solutions, and it is as if there had no alternative. So all these criteria should be taken into account and should matter in choosing what is a good and an effective and a performant measures. Now there are many studies showing that some of the measures which have been implemented are actually demonstrated to have more collateral damage than benefits. For instance, school closure have little effect on virus circulation, but very high impact and indirect effects on poverty and on health of the kids. And so we now know that school closure is the last thing to do in the context of this pandemic, because the benefits are very much outweighed by the costs and the negative impacts on health. And actually, it is still used, notably by my government, unfortunately. This is despite all the evidence shows that you should never do that. Now, what can we say about the policymaking processes? Well, again, we know what are the best practice of strategic planning in health. The World Health Organization, WHO, has issued a full handbook on how to do a good strategic planning for health. And the first thing the handbook says that you can't find a simple solution to a complex problem, and you have to take complexity into account. This is what I said in response to the question. Another thing that we know is that you always have trade-offs between the direct benefits and the indirect costs and risk and effects of measures. So the final choice of what strategy should be implemented, it cannot be technical. It is by definition political, because it will depend on what criteria, what objectives you pursue, and what criteria you prefer. And so the decision making and priority setting in strategic planning, it should be based on first a good analysis of the situation in each context. So no copy paste from other countries, but an analysis in each context. Also an analysis of all possible solutions and alternatives in the context. And you will have to set explicit objectives and criteria. The problem is that those different objectives and criteria are often contradictory. Of course, you want to maximize health outcomes, but you also have to pay attention to equity. So what kind of, will you privilege efficiency, effectiveness, efficiency, or equity? This will be a political choice. You can't have a technical solution to that equation. It's a political choice. You also have to pay account to the responsiveness, so the responsiveness to the expectations and needs of the population. I already mentioned efficiency. So what are the costs? Where to invest money in a most efficient way? So in which measures is it? Do you have more healthy outcomes for the cost of the measures? And also to make sure that the populations are protected from financial problems due to the measures. So how can you deal with it? It's absolutely necessary to lead a transparent and inclusive and multidisciplinary policy dialogue to make all those trade-offs between the competitive and contradictory objectives and criteria. So it's very important to dialogue with the stakeholders of the health sectors, paying attention to the influence of lobbies, because in policy dialogue, you'll always have some lobbies which will try to make their own choice being finally chosen by the decision makers. And finally, I would like to yes?
Sorry. I sorry to interrupt you. It's just because I think it's important sometimes on specific topics you mention. It's interesting to have the question. You talk about lobbying because there is quite a uniform, let's say, application with some differences in some member states. I agree, but they seem to converge toward the same direction when it comes to public policy, the health policy. Are they facing the same lobbies? Why there is just seem to be, especially in the EU, just one fits all approach? They're going towards the same direction. Apart from Sweden, if you take a counter example, but how do you explain that? If I may?
I think it is one question that we should ask to the participants, because I don't have the answer. But what I can say from the countries I know is that few countries have actually organized such a transparent, inclusive, and multidisciplinary policy dialogue. In Belgium, it has not been done at all. In France, it has not been done at all. I know that in the UK, it was not done in the early phases of the pandemic. UK is no longer in the EU, I know, but later on there was a more active policy dialogue, which enabled to take other perspectives into account in the equation. But I have the feeling that the many governments in Europe have not organized such a policy dialogue with the stakeholders, and have decided in a through very limited circles on what to do, and they may be influenced by the same lobbies. Probably. There are some papers, policy analysis papers, who show, for instance, the influence on some consultancy firms on the decisions. But also, they can also be influenced by a single epistemic community. Even without looking for lobbies, if you gather around the table only people who think the same way, you will have the same output. And actually, I have the feeling that our governments are in quite a similar epistemic community, and that's why the solutions are the same. But this is something we can discuss with the participants at the end of the conference, I think. And going back to my quotations of Sir Winston Churchill, he once said that when my information changes, I alter my conclusions. What do you do, sir? And I have the feeling that the information has changed a lot. The evidence-based has evolved a lot during the pandemic, but the many governments are still stuck in the first beliefs and not evidence about this pandemic. And it is very difficult for them when they have taken a decision, for instance, a lockdown or school closure. It's very difficult for them to question what they have done and to take the new evidence into account, not to repeat what was actually a mistake. So my question is, have these principles of good strategic planning in health been conducted in European countries? And the answer is definitely no. While we know that it should have been done if one had wanted to have a coherent strategic plan to respond to the pandemic. My interpretation, it's not only mine. I've worked with, I will show later my references. I've worked on these topics with several colleagues from 4 continents, and our interpretation is that the original sins at the origin of this failure, of this policy failure in the management of the pandemic, lies in the fact that we have forgotten about the basic definition of health, which is defined by the WHO Constitution, the WHO Constitution, as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So for 20 months now, we have the feeling that many governments see only one disease, and they have forgotten about what health is all about. So the focus was exclusively on the virus, as I said in my introduction. But the question is the virus, can it be controlled at all? Remember that we know it is an airborne zoonosis. So you can't control a virus which is airborne when, for instance, people get contaminated in their buildings, etc. And you can't control a zoonosis only through controlling human beings. We also know that the real vast majority of people who have disease from COVID-19 actually had one or more comorbidities. There is a study in the US saying that 99% of the deceased people in hospitals in the US had at least one comorbidity, and some had above, I think a quarter of them had above 15 comorbidities. And so these comorbidities are part of the equation, and they should be targeted as well by measures. It is also recognized that COVID-19, it's not a pandemic, it's a syndemic. A syndemic is a combination of different pandemics which take place at the same time, hit the same populations, and actually have synergies between them. It has been proclaimed by Richard Horton, the editor-in-chief of The Lancet. So especially what we know about COVID-19 is that it is intrinsically linked with the pandemic of malnutrition and obesity. And as always in health, the social determinants have a major role in determining the health outcomes. It means that COVID-19 doesn't hit everyone in the same way. You are kind of programmed, depending on your socioeconomic profile. You will have more chances to be hit by the disease. So in one paper, we argue that it's very, if you want to manage this pandemic, it's very important to distinguish between exposure to the virus, the infection with the virus, and the actual disease. So SARS-CoV-2 is not the only factor explaining COVID-19. It is the interaction between the virus and a number of factors which are very well known from the literature. So if you want to deal with and to manage to respond to the disease, you don't have to focus exclusively on the virus. You also have to focus on those factors which cause the disease together with the virus. In another paper, we have used a very provocative title. We asked COVID-19, is it an extraterrestrial disease? Because the worldwide response to the disease was unprecedented. And COVID-19 is exceptional in the response it prompted worldwide. And actually, the good old principles of public health and of medicine have been totally forgotten in the management of the pandemic, especially the targeting of vulnerable population. It has been totally forgotten by most governments. And also another problem is that many governments started and enacted that there was no cure to COVID-19. And so they did not encourage early treatment by primary healthcare professionals. Why we know that there are plenty of different paths of the evolution of the disease, which can be treated if treated early enough in the progress of the disease. And finally, another original sin lies in the proportionality of the response compared to the actual risk and a lack of risk management. In a very recent paper, we have tried to compare the risks of COVID-19 compared to other health risks. And we insist on the fact that it's very important to distinguish between the case fatality rate, so the official number of people who were recorded as a case of COVID-19, and the real infection fatality rate, which is far lower. And we know that the actual infection fatality rate is quite low. It's about 0.2%, even if it is higher for older people. And so compared to other health risks, COVID-19 is not that dangerous. It's not that risky. And we argue that there is a perception of very high risk, which is not actually evidence-based. And we see that in many contexts, the seroprevalence rate shows that there are plenty of people who have been infected and even didn't know it because they did not develop symptoms. For instance, a recent meta-evaluation showed that as far as 30% of all infections are totally asymptomatic. Another problem with the management of this pandemic is that at the global level and in most countries, the governments have bet the farm on vaccines. There was a disproportionate investment in vaccines since the start of the pandemic, but this is at the expense of the other pillars of the response to an epidemic. Now there are more than $13 billion awarded to vaccine development, but the other pillars of pandemic management, especially tests, treatments, and health system strengthening, are lagging behind with huge funding gaps worldwide. Yet, there remains a lot of uncertainties about the vaccine gamble. So the governments have bet on the vaccine to get out of the pandemic, but there are so many uncertainties about that gamble. There are still unknowns. As for the medium-term performance and sustainability of the strategy, so what is the efficacy of the vaccines in various populations? We now know that immunity wanes very quickly. Actually, after a few months, you are no longer protected by your 2 doses. So now in many European countries, people are getting their 3rd dose, but how many doses, how many boosters will be necessary, how frequent will they be necessary? It's still unknown. We also know that there are very high proportion of this virus to mutate, and there are new variants which are coming, and we don't know the efficacy of the vaccines against the variants, and we still have a lot of unknowns regarding the side effects at the medium terms of those vaccines. And so the benefit-risk balance of the vaccines are not only largely unknown over the medium terms, because we don't know the medium-term benefits and we don't know the medium-term side effects and risks. But it is also extremely variable in the short term. So since the COVID-19 disease hits people in such a variable way, I mentioned at the beginning that the lethality goes from 1 to 1,000 when you turn between 25 and 85 years of age. So is the benefit-risk balance. So it's extremely variable for depending on the situation of each individual. And we also know that there cannot be herd immunity with vaccines alone, and we need some, in a way, a natural immunity to reach the thresholds of herd immunity. So we argue in a paper that on the one hand, the policy, the vaccine strategy should rest on a strong risk-benefit analysis, not general, but based on the analysis for each individual, depending on his or her profile. And also the precaution principle should guide the vaccination policy. And there is a real case for immunization policy, which is targeted on a high-risk population. And anyway, we know that a more diversified response to COVID-19 and to future disease is needed, and vaccines will not solve the problem on its own. It's not a magic bullet solution. So now, after that grim picture of the management of the pandemic in Europe and elsewhere, I would like to propose a number of ways forward for real public health policy. So unless you have a new question, because I conclude on a more positive note.
I do have a lot of questions, but yeah, perhaps we'll do a question answer session afterwards. So it would be nice to have the positive note just to cheer up a bit.
Yes.
Before we put our hands in the dirt. So yes.
Okay. So what are the alternatives? What are the ways forward now? With all we have gathered as information on COVID-19? First, I would plead for recognizing the complexity of COVID-19. And so, since it is a complex problem, you can't model it through complicated models, and you will not find a blueprint or magic bullet. You will have to take this complexity also in considerations to develop the response. And second, you also have to recognize the heterogeneity of COVID-19. So forget about one-size-fits-all policies. It's really important to go back to the basic principles of public health, which say that you first have to identify the vulnerable populations and to tailor the responses to the different categories of vulnerable populations. And so stop implementing the same policies for all, to the young, to the old, to those who have already been infected, etc. It's also important to see beyond the virus and to target the comorbidities and then to prevent the transition from infection to disease. Most of the response has been targeted on preventing infection, but actually it's a zoonosis. It's airborne, and the vaccines are immunity is winning. So you will not manage to stop infection, but you can act on preventing the turning point from infection to disease. It's also important to develop agile measures depending on the evolution of the context and the knowledge base, and so not to be afraid of stopping a measure at some time, and especially to leaving to lifting measures in summer times when we know that there will be a period without a lot of epidemic circulations. And most of all, it's important to minimize collateral damage. For instance, school closures, as I said, have been shown to to be the last resort, and to have more problems, more negative effects than positive results. So, on the contrary, it is demonstrated now that if you correctly implement air filtration devices in closed environment, you can suppress 95% of the virus. So why do not equip school classes with correct filtration devices? From a governance perspective, it's very important to set transparent health objectives. And now in many countries, we no longer know what the objective is. At the beginning, it was flattening the curve or saving the NHS in the UK. But what is the objective now? Okay, now in many European countries, you have a lot of pressure on hospitals. But what has been done to protect the hospitals and to strengthen the hospitals and to take early treatment into the policy? So it's very important that the objectives are transparent, are clear, and also that the decision criteria are also transparent. Especially to make the population understand what the trade-offs are. And as I explained, a good policy should be rested on inclusive policy dialogue and to the taking account of the proportionality in regards to all the effects of the measures. It's also important, of course, to evaluate past interventions. I'm working quite often as a consultant for the European Commission in development projects and programs. And in that field, the European Commission always takes 15% of the budget of a program to evaluate it. What is the budget dedicated to evaluating the interventions in the COVID-19 response? I haven't seen much of it. This is especially important to learn from the experience and to get accountable to the population. Another point is that it is very important to stop the command and control. The response has been implemented to date. It is also very much known in public health, and it was the subject of an editorial of the just recent, of the latest issue of the bulletin of the World Health Organization. If you want to have a health policy which is performing, you have to build responses on social participation and on the expectations and capacities of communities, instead of taking people for stupid children and commanding them. And finally, it's important to rest not only on the hope of the magic bullet solution, like a magic bullet vaccine. It will not solve all the problems alone. And it's important to build and to rest on a mix of strategies, including continuity of care, health promotion, early treatment, and the strengthening of health systems, and especially at the primary health care. We know for decades that primary health care is more efficient and more equitable than hospital care. And where is primary health care in the response to this pandemic? We know that health promotions take time, but it is possible. We have been in this pandemic for 20 months, or for nearly 22 months now. And COVID-19 is turning endemic, so we have to look at the future and to adopt a real strategic health planning process. So I hope this will give hope to you and most of all to our decision makers to build a better response over the medium terms. Here are the references. It's all the papers I wrote with my colleagues, but of course there are dozens of references in these papers. You can get them online, and I also use the data from our World in Data to support my presentation. So thank you very much. I'm going to stop the sharing of my screen and to respond to your questions.
Thank you, Elizabeth. It was very, very interesting. It's nice we finish on a positive note. But what should we do? Because all of this is just so common sense. I mean, those are factual, scientific, political elements you share with us. How on earth do we change the current trend? Because if you read the news day by day, which honestly it's very difficult to get demotivated or disinspirited, because there's a, I don't know, is it a sense of panic or escalation? In some countries they want to implement 2G. They lock down non-vaccinated people or they discriminate them. They even consider mandatory vaccination. The new sexy topic now is the vaccination of children. I mean, how on earth do we stop that insanity in a way? Because, as you say, it has to be rational, it has to be assessed, it has to be global. We need to have a global answer. But which means do we have as, you know, as expert in our fields? We have a lot of lawyers in our team. How on earth can we change the current policies, because it seems that it's completely out of control and out of hand? How do we get out of there? Do you have any solution? Do we have to, I mean, even if we lobby, we won't have the weight of the big actors lobbying currently right now. So any ideas? Sorry, just because we finished on a positive note, I was wondering what concretely you think we should do, or what could change the current trend in policies.
Well, I recently, for the Belgians among us, I recently wrote a carte blanche, a tribune, une tribune in the press, just to say, to point to all the governance. It's a governance issue, huh? The governments have been totally left free hands. The parliaments have not played their roles. The civil society has not played its role. So there is a real governance problem, and I think what we can do is to use the medias, including the official medias, to explain people that we are no longer in emergency. We should get out of the emergency mode. We are no longer in emergency. It's not a disease we don't know. It's not a virus which is very lethal. There has not been the excess death. Actually, for instance, in Belgium, there hasn't been excess death due to COVID-19 since the beginning of this year. So this needs to be explained, because I have the feeling that many decision makers and a large part of the population still is in a psychological state of fear, and just is persuaded that they are going to die. And we have to explain that it's not that. There are a lot of structural problems which have been exacerbated by the COVID-19, but COVID-19 is no more a threat than plenty of other things. And you have to put back COVID-19 into perspectives and to educate on the real important health threats of our societies.
Yes, thank you. Well, we're trying, and I recommend everybody to read your carte blanche, because it was absolutely magnificent. And but it seems that nothing gets through. so voila. And when you hear that on the Codeco of the 22nd of December, if you read the article of the Morgen of today or yesterday, I forgot. Basically, what's on the table of negotiation of the next Codeco, for those who are in Belgium, is the 2G and mandatory vaccination. So we're going to have a lot of work at Notre Bon Droit, as usual, in the coming months. But legally and scientifically, there's no foundation of any of those measures. It's just really bad. I was wondering, could you, maybe you don't know, but we heard in the news that there was going to be this kind of treaty between member states and some states with WHO about a pandemic treaty. Do you think it's a good thing? Or, I mean, as a lawyer, I just have a lot of objections, but from your perspective, does it make sense?
Yes.
And why are they doing it?
Yes, I follow the discussion from very far away. Actually, it has been discussed for a long time, because you probably know that at the WHO level and all the member states of WHO, so all the European countries, there is what we call the International Health Regulations, which is a treaty which explains what countries should do when there is a threat of international concern. And the current pandemic has shown the limits of the international health regulations. So they are being reviewed at the moment. And there is also a lot of dialogue about pandemic treaty, but everything depends on, first, what is in that treaty, and second, what will be the implementation strength and power of the treaty. Because a treaty is about how do you get, if it's not compulsory, you can. It's useless. You know, all our countries have signed the declarations on universal health coverage, on primary health care, the international health regulations. We are all members. All our countries have committed to respect human rights, but they don't. They just don't. So I'm not very confident in the power of a pandemic treaty to change anything.
Yes, exactly. But okay, here we are amongst us, and even in replay for those who cannot attend because we're not many people. Because I realize there are a lot of shadow meetings right now in EP. So in replay there will be many more persons. But the thing is that that's the beauty of international law, is that it's not immediately legally binding, so they can respect whatever they want to respect. Convention, treaties, even they ratify them, as you know, there's no legally binding opposability, immediate one. So yeah, I know. So yeah, people are worrying a lot, but I keep repeating that at EU level, member states are exclusively competent for those issues. So voilà, they should, yes.
And so, a message I would like to convey is that the solutions will not be technical. I see that in the chats, in the comments here, people are speaking about the electronic health pass. It's not a sanitary tool. It's not a sanitary device. Of course, it will do absolutely nothing on the epidemic, and it's not a health tool. The question is not technical. The question is political. And I'm not entitled. I'm a technocrat of health policies. I also work for Gavi Alliance sometimes as a consultant, but we know how to manage an epidemic, and it's not. We are not using the good principles of how to manage a pandemic. To manage a pandemic, you have to trust communities, to target vulnerable populations, and to empower them to protect themselves. No epidemic has ever been managed through a command and control way. We are not doing what we know would be good from a public health perspective. And I'm very concerned of the side effects of the measures on the overall health on the general health outcomes of the populations. We have focused so much on the disease, this disease, that we have forgotten all the other aspects of health. And I think we have the measures, response measures, have killed more than the pandemic than the COVID-19 in many countries, especially in low-income countries.
Yes, but That's exactly the point. When you read in the news, you say in your slide, and we know it, it's a zoonosis disease. So it's correct me if I'm wrong. If I understand well, it's impossible to have herd immunity. You will never. It's like flu. It will keep. It's going to be seasonal. It will keep coming and changing. It's correct.
Mm-hmm.
Yeah, exactly. Yes. So why
exactly.
on earth people consider that suddenly, even with new technology, I stress we have no clue about in the long-term effects. They believe that this solution of vaccine was the only way, the only path to make us back to freedom and be free again and be out of the pandemic. How scientifically could they even consider this? I just don't understand. And just to make a data input, you know that for the union, the commission committed to buy 1.8 billion doses of mRNA vaccine. And then in the meantime, some members of parliament, but this we have to check, told us that it was not just only that, but it would be even more, 4.7 billion doses to be committed, which, if I'm correct, is 7.5 billion doses. I remind you, and you know it, with 450 million people. And at the same time, the EMA said, I think it was yesterday or the day before, that actually the booster should be made every 3 months. So if I'm calculated right, it's 4 doses per year. Who is going to comply with that?
It's nonsense. It's really nonsense, considering that there are alternatives. They are just in a tunnel vision, and they don't. And they are still stuck on this belief that COVID-19 is an extremely dangerous disease. It is an extremely dangerous disease for the very old people and the obese ones. Point.
Yeah,
it's not a dangerous disease for most of us.
Yes.
And I see a question in this chat. So we all agree on the fact that CST, COVID check, etc., is not a health tool. So what are the appropriate measures? It's a mix of measures. We have to implement a mix of measures. First, we have to promote health, real health, and not stop focusing on this virus. And we also have to integrate the fight against the virus within all the other health problems. And we have to promote early treatments and treatment by primary healthcare practitioners, who are the ones who know the people and who can target those who will need a vaccine and those who won't, and take and treat people when they are infected. But wanting to vaccinate everyone while this disease is not dangerous for the majority of the population, it's ridiculous.
Especially because ridiculous. we don't have any. Yes, sorry, because we don't have any grasp on the long-term effects, secondary effects.
But we don't have. We don't have the. We don't know. Yes, we have a lot of uncertainties about the lasting of the positive effect, and we have no clue about the negative effect.
Yeah.
And basically, most people do not need it.
No. So, because if I may, because you can correct me and complement what I say, because I'm not sure. Julie Myoga, if it's useless. You know what we think is useless, and I'm a lawyer, and we work with a big team of scientists and renowned researcher in the world, including Elizabeth. So we're not coming out of the blue saying it's scientifically unfounded. It's just because if you take the criteria, the first criteria, just to make a background for everybody, just in case somebody don't know, it's just that the vaccine status is not the most relevant one, because saying that the vaccine is a compassion act to protect other people is a myth, because if you vaccine, you protect yourself to some extent, but you do not stop the transmission. So vaccinated people, that's the first criteria, vaccinated people can transmit the disease. So the first criteria of your pass is irrelevant. Second criteria of the past is the test. We know PCR tests on asymptomatic people depending on the cyclic threshold, and that we know for a year or more, and since the beginning, is not relevant. And being positive doesn't mean you're sick or anything. The only criteria that could work is antigenic test. That could be positive. I mean, that could be a relevant criteria, antigenic test. Fine. The third criteria, because as you know, the pass is based on the regulation on the digital certificate, and in order to have a recovery pass, you need to prove you had a PCR test at some point, and 10 days later you have a negative test. So everybody who had natural immunity via antibodies or protection via crossed immunity with their lymphocyte and T cells are not recognized. So the three criteria do not make any sense. And it's even worse when you keep 2G, meaning you keep the vaccine status and you keep the recovery status. Not only you disavow the fact that you base the whole pandemic narrative on the fact that people were positive via PCR test, but suddenly now it doesn't count anymore. And you have vaccinated people who can still infect the general public, and you have people who actually are really recovered and have some form of immunity, but they're not recognized. So that's why it doesn't make any sense. It's not that we're against. Not only all the legal problems relating to fundamental rights, the protection of data, the personal data and privacy, and that's the reason why we managed, for those who don't know, managed to prove in the first emergency injunction in the Tribunal de Première Instance of Wallonia, we won because we had the judgment saying that indeed the COVID safety kit is illegal, but to the light of Belgium and Constitution, Belgium and EU law. But
it is illegal and it is ridiculous from a health perspective.
Yeah, but how do you understand that they move now to 2G?
It's not technical, it's not scientific, it's a political decision. We have to understand that the decisions are no longer, have they ever been, they are no longer technical. They are not scientific, they are not evidence-based. This is political. The decision in Belgium to close schools is ridiculous. We know that it is worse than anything else. So it's not. People like me are screaming, crying in the desert, but the decisions are not technical. They are not scientific. They are political. And so, what can be done? It's people like you, lawyers, and it's the media, and putting pressure on the parliamentarians. I wish the parliamentarians wake up and stop letting the executive power taking all those decisions which are absolutely not coherent and totally disproportionate towards the objectives. We don't know what are objectives, what are the objectives. Yeah. And so I would like also maybe to encourage you guys to put pressures on your different constituencies to evaluate the results of the crisis management, to evaluate both the effects and the processes. I think we may have a way out of this through evaluation, but hiring real evaluators, not people who have been doing mathematics in their office for 2 years.
Yeah, we need independent experts if it's possible, yes, without any conflict of interest as well.
Credentiated evaluators.
And thank you, Paul, for correcting me. I was based on myself on the regulation, the initial regulation, but I guess, yes, you don't need I thought we needed a negative test, but thank you for correcting me, Paul. Yes, and then, yes, thank you, Arisha. Merci, Arisha, pour oui, la Cour constitutionnelle en Slovénie. Ouf, on fait un gros ouf de soulagement. Si ça venait, vous savez que nous, on a attaqué le Covid Safety Kit à Bruxelles en référé. En Wallonie, on a déjà gagné en première instance. On aura l'appel le 21 décembre. On a eu l'audience pour le Covid Safety Kit à Bruxelles en référé d'urgence le 8 décembre. Ça s'est bien passé. on verra. L'audience continue parce qu'il y avait trop à dire de notre côté. Donc l'audience continue le 17 décembre et on aura peut-être un jugement avant le début janvier. Et évidemment, il y avait l'audience, encore une fois, contre le Covid Safety Kit en Belgique à la Cour constitutionnelle. Heureusement qu'on a différentes équipes d'avocats, sinon ils ne s'en sortiraient pas. Ça s'est bien passé. On ne peut qu'espérer que le jugement revienne comme en Slovénie. Et juste pour vous dire que on fera le même pour ceux qui sont intéressés. On attaquera devant la Cour constitutionnelle toute obligation vaccinale, que ce soit des soignants de la population générale. Et on attaquera tout Covid Safety Kit si ça devient, malheureusement, les annonces du Codeco. Je ne vois pas comment ils pourraient faire ça, sachant qu'on est en procès. Mais bon, s'ils veulent mettre le 2G sur la table, nous, on est prêts aussi, parce que c'est encore plus ridicule que le pass total. Pour revenir sur la remarque de Carmen, merci Carmen. Alors, je vais demander une faveur à Elisabeth. Est-ce qu'Elisabeth, vous pourriez revenir pour une session en français? Comme ça, tout le monde sera content. On en fera d'autres, ne vous inquiétez pas.
Bien sûr.
Merci beaucoup.
Bien sûr.
Alors, je réponds pour les personnes qui ont posé des questions en français. Nathalie, oui, Nathalie, on est très embêtés avec l'histoire du Luxembourg. Je ne sais pas si vous étiez à la réunion hier du EU Staff de notre bon droit. On en a parlé. Vous pouvez nous envoyer un email si vous n'étiez pas à la réunion. Alors, l'email, je le mets dans le chat. En fait, sachant que c'est quelque chose qui est au niveau luxembourgeois, il va falloir qu'on attaque, comme on a fait en Belgique, le Covid check. Et on doit voir s'il y a des décisions dans chaque institution européenne, parce que là aussi, il faut les attaquer, comme on a fait avec le Parlement européen, puisqu'on a attaqué le Parlement européen et l'imposition au staff et aux membres du Parlement européen le certificat numérique. Comme vous savez, on a pour le moment été débouté sur nos requêtes en suspension pour vraiment une bêtise. C'est parce que quand ça a été mis en place, le Parlement était revenu complètement au régime normal de réunion et tout ça en présentiel, et on avait un régime standard de téléworking. Et pendant, évidemment, ce qui s'est passé avec le terrible variant Omicron, ce qui s'est passé, c'est que, entre-temps, pendant la procédure, le Parlement a décidé de revenir au régime maximum de télétravail et de faire toutes les réunions en ligne. Et on a donc perdu sur la requête de suspension. Le président du tribunal de l'Union n'a pas statué sur le fond et nos requêtes d'annulation sont toujours en cours. Donc on a peut-être perdu une bataille sur des circonstances un peu vraiment malheureuses sur la base de ce télétravail et ces réunions qui sont redevenues en virtuel, mais on n'abandonne rien et on a de grandes chances de gagner. Si l'état de droit existe encore et si la Cour est encore impartiale, on a de grandes chances de gagner. Dans quelques mois, puisqu'on a un examen des requêtes d'annulation de façon accélérée. Donc, on aura un jugement d'ici la fin de l'été, avant le début de l'été. Je sais, c'est long. Il y a beaucoup de choses qui peuvent se passer, mais on attaque à tous les niveaux. Donc, au Luxembourg, il va falloir qu'on fasse la même chose. On est prêt à le faire, mais on a besoin d'un bon avocat. C'est ce qu'on n'a pas. Donc, on est en train de chercher les avocats au Luxembourg pour vous aider. On ne vous oublie pas. Qu'est-ce qu'il y a d'autre, Elisabeth? Do you want to say something else? Are there other questions? Because there would be more questions in replay. That's correct.
Yes, but maybe yes, if you have
please.
If you have other questions, but anyway, I can come back in French.
Yeah, that would be great. We can organize that. And what is amazing me, just to make a remark, there's an article in Financial Times of yesterday, if I'm correct, where they say Pfizer is going to increase the price of its dose. It's going to be $100 per dose.
Of course, but Gobi, first you have to see the influence of the lobbies in terms of direct financial benefit now, but also you have all the validation of the mRNA technology, which had been lagging behind for decades. So it's an open gate for the technology platform.
Yeah, but Elizabeth, on that for mRNA. It's the new Eldorado of vaccine technology, but do we have, even if it has been there lying down for decades, we do not have any sufficient, let's say, how do you say, recul on those technology, no?
Yeah. Yes, we
because
don't.
as well, the Commission committed to buy billions of doses of mRNA vaccine for flu in case there's a pandemic.
It's crazy. It's not based on health ground. It's not. It may be based on rational grounds, but not on health grounds.
And especially because I read, and that was an article of last spring of the Institut Pasteur, the next step, and that maybe you can tell us, it was the DNA vaccine. So that was what? That was the Première Mondiale à l'Institut Pasteur, a DNA vaccine. And I thought, how legally is it even possible? So you see what I mean? It's just very bizarre. It's like a new market. Each time, it's a matter as well of money. It's an economic, you have a new niche. And so you get into the breach and it's very bizarre. Yes, it's 10:02. We did not receive much questions because we realized there are a lot of meetings because, yes, it happens right now, even if it's Friday. So do not hesitate to send us questions by email. Elizabeth will come back in French for a session.
Of course.
Thank you so much. So
you're welcome. Voilà. And if you want, yes, you have. If you want to go more in depth in some aspects, I could also.
Yes, of course, that will be really useful because, as you know, they're going to be the revision of the regulation on the EU digital certificate. Well, normally, because now everything's possible. So we hope that we will manage to have. I mean, for those who are working with Notre Bon Droit, we hope that we will manage to have some influence of members. We have no choice. And so, yes, we count on you and we will organize next week. They're going to be the live of Notre Bon Droit for the general public. Yeah? It's not just for us. We have some members of parliament who work with us and are plaintiffs to our cases. And we also invited Bernard Rentier. I don't know, Elizabeth, if you're available. You're happy to join. We're happy to have our bunch of scientists coming. And voila, we will organize this type of a dialogue between our members of parliament and scientists we have the honor to work with. So voila. And I have a question. Sorry, because we still have a few minutes. Nathalie, en fait, non, c'est la stratégie globale, c'était qu'on a attaqué sur l'élément de légalité en urgence. C'est-à-dire qu'on voulait des jugements rapides pour montrer que c'était illégal. C'est ce qui s'est passé en Wallonie, c'est ce qu'on attend à Bruxelles. Pourquoi ? Parce que l'examen de la requête d'annulation du Covid Safety Kit devant la Cour constitutionnelle, ça prend 3 mois. Donc, si on arrive déjà devant la Cour, comme on l'a fait mercredi, en disant, voilà, on arrive, on va vous montrer que c'est anticonstitutionnel, mais on a déjà un atout dans la poche, on a déjà montré qu'en première instance, c'était illégal. Donc, on gagne des points, on a l'air beaucoup plus crédible. Donc, c'était une stratégie globale d'attaquer à tous les niveaux possibles, aussi bien en urgence en référé que sur le fond pour montrer l'anticonstitutionnalité. Donc, pour le moment, on a montré que l'illégalité. Donc, en droit, il n'y a rien qui est suspendu. Mais c'est une question de temps, puisque si on gagne à la Cour constitutionnelle, tout tombe. Hein. Donc, il faut s'accrocher. Je sais que ce n'est pas facile, mais voilà, on a tous les espoirs possibles. Et alors, peut-être Elisabeth, tu peux répondre.
Oui. Pour Julie,
pour le corps médical, comment ça
en fait, il y a certains groupes de médecins qui essaient de se faire entendre depuis le tout début, mais ils sont tout de suite catalogués complotistes ou extrême droite. Mais maintenant, en Belgique, on a quand même, j'ai l'impression, un petit réveil du corps médical, des médecins généralistes qui sont ni complotistes ni extrême droite, plutôt à gauche. Qui commence à s'organiser justement pour essayer de promouvoir la médecine de première ligne, de proximité. Et donc, c'est assez récent. Je pense que beaucoup de personnes ont eu l'espoir que les choses s'arrangeraient d'elles-mêmes et n'ont pas beaucoup bougé parce qu'elles pensaient qu'on allait en sortir et que quand elles voient maintenant qu'on s'enfonce, là j'ai quand même l'impression qu'il y a beaucoup de médecins qui se réveillent, qui s'organisent pour essayer de reprendre, de redonner la médecine aux médecins. Donc j'ai un petit espoir de ce point-là.
mais on les aide en fait parce que pour ceux qui suivent, nous on travaille avec, on a la chance de travailler avec Covid Rationnel dont Elisabeth est partie. On a des contacts et une collaboration avec Réinfo Covid, aussi bien en France qu'en Belgique, et ils ont mis en place le système de Covid soins, c'est-à-dire que si vous avez des symptômes Covid, vous appelez le numéro ou l'email, et en fait, ils viennent chez vous, vous faites un test, et si vous êtes positif, ils vous donnent les traitements précoces. Nous recevons des milliers de messages par semaine, et parfois, selon les mauvais jours, enfin les bons jours, par jour. Et je suis sidérée de voir qu'il y a non seulement une discrimination et un refus d'accès aux soins par des médecins sur des personnes qui ne sont pas vaccinées. On en est toujours comme en mars 2020, s'il y a des gens qui sont testés positifs, leur médecin traitant leur dit vous restez à la maison et vous prenez un Dafalgan, et si ça empire, vous allez à l'hôpital. Donc on n'a rien appris. Je veux dire, je trouve ça dramatique, puisqu'on laisse des gens comme ça sur le carreau. Et c'est ce que dit Elisabeth. Il y a une prise de conscience, mais pour qu'il y ait une prise de conscience, il faut aider ces médecins. Ça, c'est notre rôle pour les aider, pour leur dire légalement, ils ne sont pas seuls parce qu'ils ont peur des représailles. On a fait beaucoup de pression sur les médecins et on l'a vu, on a eu des cas qui veulent faire leur travail, donc c'est très difficile. Oui, ils ont oublié de ce que ça veut dire de ce qu'être un médecin. Oui, Joe, effectivement. Mais voilà, donc je vous conseille de soutenir Covid Soins, par exemple. C'est une bonne initiative. Et on essaye de réunir l'ensemble des soignants qui nous soutiennent, qui voudraient être plaignants pour l'action que nous allons mener contre l'obligation vaccinale des soignants s'il y a une loi qui passe à un moment. Pour le moment, on se prépare. Et donc, on a peut-être 5000 soignants qui nous ont rejoints. Donc, je sais pas, combien de soignants, Elisabeth on a en quelle proportion de soignants en Belgique
Pour l'instant, là, il y a un groupe, là, le groupe que je suis, ils sont une petite centaine. Mais en Belgique francophone, les choses ne sont pas du tout comme ça en Flandre. C'est ça. En Belgique, on a la particularité qu'on est vraiment un pays divisé en deux et ça ne se passe pas du tout de la même façon de l'autre côté de la frontière linguistique.
Parce que dans notre groupe de soignants, notre bon droit, on a 4500 soignants qui nous ont rejoints. Mais je ne sais pas quelle proportion ça est par rapport au nombre de soignants total. Je ne sais pas. Mais ça n'a pas l'air non plus. Enfin, ce n'est pas 2 personnes, c'est 4500 déjà personnes soignants. Donc, ça prouve qu'il y a quand même une impulsion et qu'ils sont contre ce qui se passe actuellement, notamment la poussée de leur syndicat de dire voilà, l'obligation vaccinale, on est d'accord, mais on ne veut pas de sanctions. Et en fait, la chose la plus juste, c'est de vacciner tout le monde. Donc, voilà. Donc, il y a encore de l'espoir. Je suis d'accord avec Elisabeth. Et soutenez les médecins et surtout fuyez
les médecins, mettez la pression sur vos élus, même au niveau
les médecins
municipal.
Qui sont comme Covid soins, mais surtout quand on me dit oui, là mon dentiste veut pas me prendre parce que je suis pas vaccinée, je dis changez de dentiste et signalez votre dentiste. Là, il faut plus avoir d'état d'âme parce que c'est pas logique ce qui se passe. Et comme le dit Elisabeth, et nous vous demandons souvent à notre bon droit de le faire. C'est même plus le cas d'envoyer des lettres ou des courriers. Maintenant, vous prenez rendez-vous avec votre député et vous allez le voir en face à face pour dire ce que vous pensez. Et on met ça en place aussi avec nos équipes. Il faut lobbyer par tous les moyens possibles. Voilà. Donc, voilà. Donc, je ne sais pas. Qu'est-ce qu'il reste d'autre? Et en Autriche, pour Arisha, pour que vous sachiez, on va essayer de mettre en place, parce que la loi, si je ne me trompe pas, la loi n'est pas encore passée. Et donc, on va essayer, on est en relation avec des avocats autrichiens pour les aider, parce que moi, ça me paraît aberrant d'un point de vue légal que l'obligation vaccinale de toute une population, aussi bien en Autriche qu'en Allemagne, ça passe comme une lettre à la poste, au niveau constitutionnel. Moi, je ne comprends pas. Donc, on va se battre jusqu'au bout, parce que ce qui se passe dans ces autres États membres nous affecte aussi. Donc, on est sur le pont, là aussi. Donc, voilà. So, n'hésitez pas si vous avez des questions. Do not hesitate if you have questions. Elisabeth will come back in French next time, and we will have another session and perhaps on other issues. We will fix a date quite quickly. I would like to thank Elizabeth. I hope it was interesting for you. We will be in replay, so we will put the link on our platforms. And do not hesitate if you have questions, and send us email, and there will be new conference coming in the coming weeks. Thank you so much. Thank you, Elizabeth.
Thank you very much for inviting me, and good luck to everybody.
Yeah, that was a pleasure. And
Together
we'll
we
be-
stand, divided we fall, and don't forget it.
Yes, yes. Well, our motto for the union, we are all EU staff, is united in diversity. As I say these days, we're united in adversity. So, and we will conquer. That's the thing. Thank you so much, and have a nice afternoon. And we'll be in touch. Thank you. Bye-bye.
Bye-bye.
Thanks.